Okay, this is going to be the second part of our environmental PowerPoint that we'll be going through. We'll be talking first about drowning. Drowning by definition is going to be the process of experiencing respiratory impairment from submersion or immersion in liquid. Note it did not say water, it just said liquid. Still, some agencies might still use the term near drowning for a patient who survives for 24 hours after a drowning incident. So near drowning is someone who survives for 24 hours. A drowning is, well, obviously someone who did not. Risk factors for drowning: alcohol consumption. Obviously, we have a lot of people around water that like to partake in adult beverages. Maybe seizure disorders. People have seizures on docks, boats, in pools. Geriatrics with cardiovascular disease and any kind of access to water that might be unsupervised. And a limb spasm, please know the definition for this is when we inhale water and that water hits our larynx and causes our vocal cords to spasm, which completely shuts down our airway. So we know safety. There's the reach, throw, row, and go that we would use if we're not specifically trained in water rescue. And if you're working in a pre-hospital setting, but you're not, and you have been trained in water rescue, however, you're not working specifically with your water rescue team, remember that you might not have the equipment needed. Just because you have had the training doesn't mean that it would be a safe environment for you to go into. Recovery techniques: if we don't have patients who are floating in the water, you would obviously use organized effort, and this would require specialized personnel with scuba gear. These are going to be your dive teams that are located in your agency. Should be familiar, wherever you are, your agency should be familiar with the closest available dive team. We never give up on resuscitation efforts of a cold water drowning victim because remember, from our cold emergencies, we talk no one's dead until they are warm and dead. And also the diving reflex, I believe this might be a quiz question as well. The diving reflex may cause immediate bradycardia, which slows the heart rate. As soon as you hit cold water, your heart rate automatically drops. So that is going to be the diving reflex. Might not be a bad idea to know the definition for that. Descent emergencies. These are caused by a sudden increase in pressure as the person goes in water. I believe it's every 30 feet is considered an atmosphere. Typically when divers descend and ascend, they do so in 30-foot increments to allow their body to become used to the variance in pressure. Most of the typical areas that are affected are going to be your sinus cavities and your lungs, the ears, teeth, and your face. Lungs obviously being the life-threatening one of those. And so pain can force a diver to return to the surface to equalize pressures, and that in a lot of cases the problem will clear up by itself. However, if we perforate a tympanic membrane, that can be very painful. Remember that whenever a diver is going underwater, the deeper they go, the more pressure there is, the more their body feels like it's being squeezed from the outside, and so it's easy for them to become uncomfortable and then ascend too quickly. When we ascend too quickly, that's going to cause problems. Emergencies at the bottom it might be due to faulty connections in diving gear or whatnot. These can cause a patient to drown or have to ascend rapidly. This is a rare thing, and you might be called to deal with this as an aftermath. Obviously, it'd be very unusual for you to have to deal with one of these while underwater, as you would be part of a team in order to do so. Ascent emergencies being the exact opposite. These we usually have to be very aggressive with these. Biggest concern: air embolism. As they're coming up from the depths of the water, air embolisms can form in the body. This is very, very dangerous. air pressure in the lungs can remain high while the pressure in the chest decreases as they go up. It should be exhaling as they go up, as that pressure releases on the body, causes the lungs to expand. But this can definitely cause air bubbles to form in the vascular space and also cause barotrauma to the lungs. We talk about decompression sickness, also known as the bends. That's those bubbles of gas, mostly nitrogen, that obstruct blood vessels. These are very, very, very painful. And the only treatment for it is you're going to have to get these patients to a hyperbaric chamber. These can be caused by ascending too rapidly or staying at a depth for too long, or repeated dives within a short period of time without proper rest in between. Blockage of those tiny blood vessels can obviously inhibit circulation, and that could deprive specific body parts or areas of their normal blood supply, and it is, like I said, very painful. You're going to have the pain's going to be located in the joints and the abdomen, and you'll see the patient doubled over or what as when typically you come in contact with them. It might be difficult to distinguish between an air embolism and decompression sickness, because air embolism will be caused from or show immediately on return to the surface, whereas symptoms of decompression sickness might not show themselves for several hours after. Well, there's the hyperbaric treatment chamber I just mentioned. This is going to be the treatment for both, where it's an air embolism or decompression sickness. They'll come in, and a hyperbaric chamber basically pressurizes higher than normal atmospheric pressure, and it keeps that pressure on and to force the gas back into the appropriate space. We know how to do a scene size up. We don't have to go through that again. We know how to do a primary assessment, including a general impression and opening the airway and assessing breathing. Want to make sure that any kind of water injury, we consider the need for C-spine, and that because we don't know if our patients hit their head on anything below water, we're unable to determine that, especially if our patient has an altered level of consciousness. Remember that if our patient is wearing any kind of scuba gear or whatnot, if they've vomited, be ready to suction. We'll be ready to suction anyway, but just know there's a higher risk of aspiration if they vomited in a mask, and we might need to breathe for these patients. Circulation, same deal that we've been through numerous times, where we assess carotid pulses on unresponsive people, radial pulses for rate the rhythm equality on responsive people. If we can't feel a pulse, we'll begin CPR. And making that transport decision, if we do have any kind of decompression sickness or air embolism, we would need to go to a hyperbaric or recompression chamber, and you would need to know where central should be able to, or your central dispatch should be able to guide you to the appropriate location. We know how to take histories. We know how to do secondary assessments. We know how to reassess. So how do we care for drowning and diving emergencies? Pretty much already said that we're going to maintain airways. We're going to support ventilation, whether it be through administration of oxygen all the way to assisting ventilations with BVM. And we're going to support circulation. Maybe for shot by elevator feet to actually circulating for them through chest compressions. We'll also make sure we remember to treat for hypothermia, removing wet clothing, removing them from any kind of cold environment, and potentially actively rewarming them. For air embolisms and decompression sickness in a conscious patient, get them out of the water, keep them calm, give them oxygen, and remember there's a possibility for spontaneous pneumothorax from the pressure variant or a popping of a lung. So continually monitor breath sounds on both sides to make sure that that doesn't become an issue. Anytime we have a water-related injury or illness, I should say, incident or whatnot, we always consider hypothermia. We remember that was one of our highest probability environments. And then we have breath-holding syncope, people who might be swimming in shallow water, but holding their breath, they lose consciousness and actually can aspirate water. And how do we prevent it? I don't know. Maybe you need to go out and build fences around all the pools you see. But child drownings are primarily come from lack of adult supervision. But this is going to be the on the preventative side, obviously not on the emergency dealing, on the emergency side after the fact. In high altitude, which are literally the opposite of the underwater or water-related emergencies, we have dysbarism injuries that are caused by the difference between surrounding atmospheric pressure and the gas pressure in the body. We'll talk a little bit about altitude sickness as well, which is we know that there's less oxygen, or the oxygen molecules are farther apart in the atmosphere, leading to less oxygen in inhaled air at higher altitudes. And this can affect our, our respiratory system and our central nervous system. Acute mountain sickness, that's even diminished oxygen in the air at higher altitudes, we already talked about, caused by ascending too high or too fast, not being familiar, or your body not being acclimated to those. Might get headaches, lightheadedness, fatigue, maybe some difficulty breathing, difficulty sleeping, loss of appetite, nausea. Upon physical exertion, short physical exertion, and you may have actual shifts in the body fluids causing a swollen face. High altitude pulmonary edema, obviously a life-threatening emergency. Fluid collects in the lungs and does not allow for oxygen to transfer across that alveolar capillary membrane into the bloodstream. Shortness of breath, cough with pink sputum, the congestive heart failure type thing, cyanosis, and a rapid pulse are going to be all signs and symptoms of this. You may, anything high altitude cerebral edema can go right along with the pulmonary edema. Remember, it's because of a difference in pressure on the outside environment versus the pressure on the inside of the body. And obviously, just as pulmonary edema with fluid in the lungs would be life-threatening, cerebral edema or brain swelling would also be life-threatening. It could start off with a headache and move all the way to vomiting and loss of consciousness, and obviously eventually death if not treated appropriately. And we treat those by providing oxygen, getting them out of the environment or descend from the height, and transport promptly. Make sure that we give positive pressure ventilations for anyone who has inadequate respirations. Lightning strikes, and I know these are kind of random, but we're all outdoors and they're environmental. Lightning strikes apparently is the 5th most common cause of death from an environmental phenomenon. So people that are outside or anyone in large open areas are obviously targets for lightning strikes. Remember that lightning strikes typically don't send people. When a lightning strikes someone, they're typically go straight to a systole and not into VFib. Many of the individuals that are indirectly struck, so they don't take the full brunt of a lightning strike because they're standing near an object that's been struck, such as a tree or a metal shelter and or whatnot. But the cardiovascular and nervous systems are the things that are going to be most commonly injured. But remember that tissue damage travels through the body. So anywhere you see electricity enter the body, if there is a burn there and a burn somewhere else, that electricity has traveled completely through the body. We're unable to follow the path. We can't obviously open the body and see. So there are internal tissues that are burned, and we have to be ready to treat for any incident. Respiratory arrest or cardiac arrest are most common the most common cause of lightning strike deaths. So categories of lightning injuries: mild, moderate, and severe. As we do with most things, mild, they might have amnesia, loss of consciousness, might be a little tingly, be confused, may have some superficial burns. Moderate could lead to on those nervous system, severe nervous system problems with seizures included, possibly even not breathing, cardiac dysrhythmias, once again, superficial burns, and severe lightning injuries can develop into or lead to immediate cardiac arrest. Emergency medical care. If you're out in the lightning storm, please protect yourself. Get out of the area. Use a reverse triage. Which is, we know that triage is people who are up walking around, or the last to be seen or the last to be transported. That's not true in this case. We remove them from the environment. We'll stabilize C-spine in all cases, for the simple fact that we don't know if the patient has been thrown, fallen, or anything else. And also regarding that reverse triage, we talked about how we got our green, we've got our yellow, red, and black, or whatever. But anyone in cardiac arrest would be the first person, the first people that actually got treated because of their viability for quick recovery from that. And when I say recovery, I just simply mean return of spontaneous circulation. Let's talk about spider bites. There's a lot of spiders out there, only a couple of them that'll actually hurt you in the United States. The female black widow and the brown recluse deliver serious or life-threatening bites. Here's a picture of a black widow. Fairly large, can be approximately 2 inches across, has that distinctive bright orange or red marking in the shape of an hourglass or violin on the abdomen. They're found everywhere in the United States of America except Alaska. They like to live in dim, dry places. Sometimes it's not a painful bite when it first occurs, and sometimes it's overlooked, but then localized pain can occur over the course of the next few hours, and it could lead into muscle spasms. The biggest danger, which we're talking about envenomation, so obviously the biggest danger would be the venom, but it is poisonous to nerve tissues, or it's a neurotoxin, if you will. And so you might see some systemic changes. They might be dizzy, they might be sweating, nausea and vomiting, maybe a rash systemically if they have any kind of allergic response. They might have some tightness in the chest or severe cramps. But generally, black widow spider bite, within a couple of days or whatever, these symptoms are going to pass. If you do have to transport this patient, most of the time it's just BLS for any patient who might be having respiratory distress. And obviously we would manage that airway and support ventilation appropriately and transport as quickly as possible. But low-grade fever, a lot of joint pain, these are going to be the things that are typically associated with a black widow. When we start talking about a brown recluse, though, we start talking about something that causes tissue necrosis. They're dull brown. They're only about 1 inch. They have a violin shape on their back. Mostly live in southern and central parts of the country. So yes, that's right. In North Carolina, welcome. We have brown recluse. They like dark areas. They have a cytotoxic venom, severe tissue damage. Once again, bite's not really painful at first, but can become so within hours, and then the area around it gets swollen and starts developing a pale mottled color. Can actually blister in the center, and you might see it form a scab of like dead skin or whatever, and that literally forms an ulcer in the skin. So it sounds pretty nasty, and that's because it is pretty nasty. Rarely do you see any kind of systemic signs from a brown recluse bite, but it's mostly localized at the side of the bite. But just know that that tissue necrosis may continue on and on and on until the point that there has to be surgical intervention. Sideline, friend of mine's mother was bitten on her thigh, and after 6 months of trying to deal with this, whatever, they actually ended up having to take out a significant piece of her quadricep because they could not contain the spread of the tissue necrosis. And it was, had it gone on much longer, she could have lost a leg. So stings are a big thing. Everybody has probably been stung. If not, you need to spend more time outdoors and experience life. But bees, wasps, yellow jackets, ants, all these things can sting us, and they're maybe painful, but they're not typically a medical emergency. We can use a technique called a Stingerectomy by using the flat, firm edge of something like a credit card or a driver's license to scrape any venom sac that might still be in our skin away or whatever. Obviously, we wouldn't use tweezers, because if we were to squeeze that sac, then we would squeeze whatever venom was still in it into our patient. And if our patient is allergic to the venom, anaphylaxis may occur. And so we would obviously be ready to treat that. Snake bites, there's a lot of different kinds of snakes that are poisonous. But in North Carolina, we only have 4. We have a rattlesnake, copperhead, Moccasin, and coral snakes, which closely resemble corn snakes. So we have here we have the up top we have the rattlesnake. You can see right here we have the rattler, whatever. If you can hear the rattle, you're too close, back away. Here we have the copperhead. The biggest danger there is they blend into leafy undergrowth. We have here the cottonmouth water moccasin, which they grow to be about 3 feet, but they're quite thick, and they're very aggressive as well. And coral snakes, which have a distinctive red on black, I'm sorry, yellow on black pattern. I don't remember what there's a saying that goes along with it. Oh, it's a red on yellow will kill a fellow. However, red on black is a friend of Jack. So if you, I know you're probably never going to remember that, and that's fine. But the color pattern looks very much like a corn snake that we also have here with the red and the black and the yellow. It's just they're in a different order. So snakes don't usually bite unless they're provoked, so don't poke it with a stick. However, if your patient has poked it with a stick or accidentally stepped on it or whatever, the thing you want to do is protect yourself. Make sure you don't get bitten. Make sure you use the appropriate PPE. Appearance of a poisonous snake bite is usually 2 small puncture wounds, and you've got swelling and discoloration around the area. Rattlesnakes, copperheads, cottonmouths are they're named for the small pits located just behind each nostril in front of each eye. I'm sure you'll get nose to nose with each one of these snakes to determine if it is a pit viper or not. Rattlesnakes are the most common form. Copperheads are usually 2 to 3 feet long. Copperheads are rarely fatal, but you can have significant tissue damage. Cottonmouths are very, very aggressive. They are grumpy by nature. They may cause severe tissue damage as well. But anytime someone's been envenomated, burning at the site, swelling and a blue discoloration, they may have nausea and vomiting, potentially even some weakness, sweating, and they may have passed out or even be having seizure-like activities. Also could have some vision problems, blurred vision or lack of vision, changes in level of consciousness, and all signs of shock. If there's any swelling, use a pin to mark around the outside edges, and that way on the way to the hospital or later at the hospital, they'll be able to see if that is spread outside of your initial marks. How do we treat it? Put them in a calm the patient, put them in a supine position, let them rest. If we need to clean the area, we'll clean it with soap and water. No, we are not going to make an incision in between the 2 bite marks and suck any poison out. We're just going to clean it, wrap it, be alert for any kind of anaphylactic reaction that we might have to treat with epinephrine, and we're not going to give them anything by mouth. We'll be alert, asking them if they feel nauseous and be ready for our patient to vomit. If the bite occurred on the trunk or the torso of the body, we're going to make sure, same thing, lay them down, keep them quiet, transport as quickly as possible, and treat for any kinds of shock. If the snake has been killed, they say bring it with you. Most people will not do that, but in today's world, we usually have a device with us where we can take a picture of it before we transport to the hospital. Coral snakes are small. They're obviously located near the coast as a general rule. Uses a chewing motion, leaving puncture wounds, can cause paralysis within a few hours of being bitten. You could have some bizarre behavior, and patient's respiratory system can be paralyzed as well. And the same emergency care is going to be the same as it would be for the other 3. Scorpions are arachnids with a venom gland and a stinger at the end of their tail. They're rare. They live usually in the southwestern parts of the United States, although we do have them some in North Carolina. And there's only one exception. With one exception, scorpion stings are painful, but they're not usually dangerous. And there is your typical scorpion. The exception is the, you can say that at your leisure, Centrudo. I'm sorry, not into arachnids, but the venom can actually cause circulatory collapse. And tick bites. We have lots of tick bites here in North Carolina. Anyone that says that ticks fall out of trees onto you are a little bit mistaken. They're usually ground dwellers. You'll find them. They do climb in bushes and shrubs. They can be small. And our biggest problem with them is the infectious diseases that can travel through their saliva. They attach themselves primarily to the skin. They climb, and then when they find an area where they are compressed, such as a sock or a waistband, the liner or the edges of traditional underwear or briefs or whatever, once they feel like they're being pinched or whatnot, they typically seize on because they feel warm and safe, and they bury their head in the patient. So the big danger is not from the bite itself, it's what diseases they can transfer. They can transfer Rocky Mountain spotted fever. So remember, if you have patients that have symptoms of nausea, vomiting, headache, weakness, paralysis, and possibly even cardiorespiratory collapse, one of the questions you would like to ask are, is there a possibility they've been bitten within the last week or so by a tick? Lyme disease is also reported in all states except for Hawaii. Initially, you'll have fever and flu-like symptoms with a bullseye rash that can spread to several parts of the body, but you start having painful swelling in the joints and can actually mimic rheumatoid arthritis until your patient can literally just become unresponsive. Obviously, tick bites occur mostly during the summer months, but remove the tick by using and then pull it straight out. Don't yank it. If you pull gently on it, there's a high probability it will let go. Once that area is removed, wipe it down with antiseptic and save the tick. Take it with you to the hospital. Do not use all the old remedies that everyone told you. Strike a match, blow it out, and touch it to the tick's back, because that will make it let go. That actually might cause it to burrow deeper into the skin. And finally, injuries from marine animals. For anyone who's working at the coast, we have jellyfish, fire coral, Portuguese man-of-war, sea wasps, sea nettles, just regular jellyfish, sea anemones, different coral or whatever, and there are pictures of those. If you live at the coast, you want to be aware that these things exist. You want to be aware that the envenomation from a sting from one of these can cause an anaphylactic reaction. They can be very, very painful. They can leave red lesions on people, and also lead to muscle cramps and even fainting. And our emergency treatment is obviously going to be keeping the patient calm, reduce the motion or stabilize the extremities. Any remaining tentacles, we can scrape them off with the edge like a car and provide transport to the emergency department. We are not going to use things like ammonia, household remedies, and pour on them or whatnot, like we've been told for years and years and years. We're just going to clear it, clean it, and transport it. And that is going to be the end of our part 2 of our environmental emergencies.